Welcome, everyone. My name is Chris Buller. I'm an interventional cardiologist, so I'm outside my comfort zone at this conference. I'm a chip operator from Toronto and the medical director for Teleflex. And so I'm going to learn a lot today, and I'm really looking forward to that. I may have some questions to catch up with all of you. We have a presentation today for which the theme is optimal patient care, and the thread running through the talks is balloon pump. But optimum patient care is the forward theme that we want our speakers to emphasize for you. So it's about the patient. And we have distinctly different talks. All the symposia I've ever chaired over my career, I've never introduced a physiotherapist, which is, an indictment of me, not of Gary. Incredible contributions to our patients' care. And he has 20 years of experience in ambulation and physiotherapy, recovery, rehabilitation of critically ill cardiac patients. And Gary's really passionate, almost evangelical in the best sense of the word, about early ambulation in critically ill cardiac patients. Deeply experienced, and he's going to give a talk which for me is counterintuitive about the ambulation of patients with a transfemoral balloon pump. And finally, we're going to finish with someone you suspect most of you know well by reputation, if not personally, and that's Dr. Will Grandin from Beth Israel, who runs the temporary MCS program and ECMO program at Beth Israel. Transplant cardiologist, thought leader, incredibly nuanced clinician by all accounts. And he's going to be speaking really about individualization of MCS therapies, which patients, if any, are suitable for balloon pumps in his practice, how do you identify them, what are the alternatives, and how does he think about it? So those are our speakers. Gary, the floor is yours.
Fantastic. Thank you, Dr. Buller. Just to start off, I want to offer some clarification. My background is in rehab. So for 10 years, I spent in rehab, skilled nursing facilities and inpatient rehab, working with folks for 3 hours a day to make sure that they can get home, right? And so it's been the last 10 years that I've been doing critical care. And so within that time frame, I've only been at UVA for about 2.5 years. And prior to that, I was at a level 2 trauma center in a community-based, non-academic center, actually working with folks, multidisciplinary teams, developing protocols and guidelines so we can mitigate deleterious effects of bed rest. That includes mobilizing people with perceived barriers such as special lines. And so we'll start off there. And so my disclosure, I have nothing to disclose at this point. This is the acronym page. I'm going to save some time for the next speaker to go through his entire acronym page and move forward. Okay? I'll go to the objectives. This is what I'm hoping to share with you in the next 10 to 15 minutes. And at this point, I want to start off with the bottom piece. There's 4,500 people that came to this conference. 4,500 people walked through these doors. There's less than 249 people here today that walked through those doors with lunch and sat down. You will stand up again and go to your next talk. That's mobility. And I want to highlight that. That's just mobility, the ability or capacity to move. Rehab is different than mobility. Rehab works with folks who have had a significant functional decline, whether it be a big stroke, whether they smacked their toe on a concrete floor walking into a garage, right? Whatever it might be, rehab works with folks who've had a significant functional decline to get back to their previous self. And so mobility is just one tool that rehab uses. There's another piece that I want to talk about before moving forward to ambulating with balloon pumps, and that's perception, right? And so I like the thought of this definition. It's a physical sensation interpreted in the light of experience, right? If you can go back to the first gut-wrenching time that you had to perform an invasive procedure, that was gut-wrenching. That was the physical sensation on that first patient that you had to put a femoral arc line in, right? Or intubate. You knew it was right for the patient. It's a 6. But what the hell am I doing? It's a 9, right? And as you gained experience, you became to understand that it's not as difficult as it was perceived to be. And so we do the same thing with critical lines, whether it be a FemArt line, because there are still places that do not mobilize people if they have a FemArt line, whether it be FemECMO. Places are still not mobilizing people who are on FemECMO. There's evidence, and that's the bridge that we use to help bring multidisciplinary teams together to create and collaborate guidelines to move forward and provide best evidence-based care. And that's what happened at UVA. Before June of 2019, if somebody was cannula with FemECMO, or if they had a femoral balloon pump, strict bed rest, right? And so they would lay in bed, they would do their prehab in bed. They would roll onto a bedpan, and they would engage with their family in bed. After 2019, after multidisciplinary teams got together and collaborated, they were able to secure standing beds. That allowed our patients to get weight bearing. That allowed our patients to do prehab in an upright position. That allowed our patients to eat in an upright position. In March of 2023, using Ramsey protocol guidelines, we looked at how can we move forward to mobilizing our folks in balloon pumps. We'd already started mobilizing folks with FemECMO. They could sit at the edge of the bed. They could sit in a recliner. They could walk through the halls. They no longer required the standing bed. But our folks with a balloon pump still required a standing bed. But Ramsey allowed us to move forward using that evidence. And that's where the guideline development begins. Identifying specific strategies for inclusion and exclusion criteria specific to your facility, right? And so when Ramsey developed his protocol, he used a tilt table. We had a standing bed. That's different, but the evidence was there and it was safe. The other piece that you look here is if the person is awake and able to participate, that's the person that we want. If they're not able to actively engage or they become hemodynamically unstable during verticalization, that's probably not a time to try ambulation. The minimum needs of ambulating our clientele is something that we looked at, right? And so as we start moving forward, how can we reduce the noise? And some of that noise was how many drugs and how many pumps were required so we could move forward. Can we put them all on one pole? Can we put them on the balloon pump console? How much help and support do we need to mobilize somebody? We came up with 3 people. One person to specifically focus on the mobilization of that patient. One person to manage the hemodynamic stability as well as the balloon pump during that ambulation. And then one person to follow with a striker chair to ensure that if something were to go south, there was a way to fix that safely. And so we didn't start with, okay, you're cannulated, let's walk. We started with, you're cannulated, let's verticalize. Can the patient tolerate that? If they can tolerate the verticalization, then we look at strength. Do they have the ability to actively participate with the ambulation process? If not, we start with verticalization and engaging with patient through rehab to build up the strength to move to the next step. And then we had to identify exit strategies at our facility. And so striker chairs are something that we use because it goes automatically flat and we can follow the patient and get them down safely if needed. Other facilities use rollators and let them sit less than 30 degrees on that rollator before they can get them back up and moving. And so that is specific to an institution. In addition to the guideline development, we also looked at developing an EMR smart phrase. And this allowed for consistent clinical assessment. Okay? And so within our EMR, these are all drop boxes. RAS, are they awake enough in order to participate? Cannula locations, left, right, axillary. Cannula site, is it stable? Yes. Secondary anchor, is it intact? Yes. Measurement of the metal tubing external to the patient in centimeters. And so we look at that as a measurement from the proximal hub to the distal hub and that exposed metal tubing to ensure that there's not migration pre and post ambulation. And then we use clinical skills. Are there pulses? Do they have cap refill? What's the temperature bilaterally? things that we do, that nursing was doing on a daily with somebody who has a balloon pump. Included in that is left radial pulse, before and after. We use this SMART phrase to ensure that all professionals who are ambulating these folks on balloon pumps did the exact same thing and that those protocols were followed. And so why go through all of this, right? Wouldn't it be easier to just let this person lay in bed, right? Less people, less resources in order to just let that person lay in bed. That would be easiest. But that's not the patient we want as a bridge to transplant. The patient we want is to be actively engaged in their care. And that's why we do it. Quick story. We had a 35-ish-year-old new, soon-to-be father laying in bed. We were still at the point of just verticalization, and he was ready for his heart transplant until he wasn't, right? Days turned into weeks. Emotionally and physically, you watched him deteriorate to the point where he didn't want the lights on in the room anymore because the lights were too harsh. And of course, that led to muscle wasting because he didn't want to verticalize anymore because that was too hurtful, too painful. And so here he is becoming more delirious with his loving wife beside him who's about ready to give birth to a child. Thankfully, he got his heart transplant. Thankfully, we were able to rehab him to the point where he could go home and be the father he is today. He had choices. Oh, no, we got to look at the alternative, right? This is the alternative. Laying in bed, a ceiling, 4 walls, his prison for the time that he's there. That's not how we want our patients. We want our patients to be active and engaged. And so anecdotal benefits at UVA that you see with these folks, right? For those who are concerned about fluid management, you can get real standing weights on the daily, right? We get all the benefits of upright and moving by being upright and moving. So decreased pressure ulcer, increased vascular tone, increased strength, increased ability to participate in rehab actively. And so this is data that we have to date. We've had 14 patients with a formerly inserted balloon pump, 145 plus trials, averaging about 200 meters per ambulation trial. 11 out of those 14 have gone directly home post-transplant. No pit stops. 2 have gone to rehab. 1 is waiting for their heart transplant. And no major adverse events during this process. And so what I want to share is some of our journey through this. This is our first patient on his second ambulation trial. We went outside with his sister. What you'll see, there's going to be more people in this picture than required. Why? Because we're training. We were blessed to have a nurse who had come from a center that was already ambulating folks with balloon pumps. And so she was able to use those alarms that triggered that said, hey, there's a helium loss, or hey, we're not picking up the ECG trigger that we anticipated. She was able to defer some of that and say, that's not a big deal. Here's what you do during that situation. We had partners with our balloon pump folk to say, hey, we're having some challenges with these alarms. Are they real alarms or are they perceived alarms? And so we were able to work through some of that. He got outside for the first time with his sister. Let me see if I can get it. They're going to turn it down in a second. But I wanted to share with you, this is a Hokie football player from back in the day.
At the stadium.
And so part of his engagement was him taking us through what it was like coming through the tunnel during Enter Sandman, for those who can appreciate that. Right? And so he would be there waiting, hit the Hokie stone, and in we came at UVA. Right? Not a Hokie place, but that's our patient.
Good job.
That's his wife.
Security go.
Sorry, I'm not sure why it kept playing. But that was his wife filming that, actively engaged in the care of that patient. This young man is walking with his granddaughter. This is where I get a little choked up, because she would come in while her granddad is waiting heart transplant, and the nurses would give her a stethoscope so she could listen to his heartbeat. There's no physical therapist here. We'd gotten past the point where he required a walker. He had rehab back to the point where this is just mobility. Nursing is mobilizing our folks who don't require PT anymore. He had a balloon pump for 30 days. He discharged home in less than 2 weeks after transplant. We discharged PT after transplant in about 7 days because he was up walking the halls, fully dressed, holding his wife's hand. He didn't need PT anymore. He was just waiting for that second biopsy before he could go home. He holds the record currently for walking the furthest with a balloon pump, only about 900 meters, right, in one trial, which he couldn't do before he had the balloon pump. Too short a breath. And so I share with you that it's our opportunity to give back to our patients and not be stymied by perceived barriers. And so I'll leave that with you for now.
Great. That was terrific. Will Grandin, you're up. Tough act to follow.
Extremely. Love that, Gary. Dr. Buller and team, thank you for the invitation and particularly for the grandiose introduction earlier. I don't know if I've ever felt better about myself. I've noticed that many people are sitting far away from the podium, but we see you, and we're going to be doing some audience participation, so get ready. And if you don't participate, Gary's going to put on Enter Sandman again, and we're going to get fired up. Did they just come up? It's advancing here. Aha. Oh, good. This is our best slide. I'm going to be talking. Does this go back? There we go. I'll be talking about intra-aortic balloon pump as a strategy to bridge patients to heart transplant, and thinking particularly about how we select patients that may most favorably respond to this strategy. By way of disclosures, I do some consulting work for Teleflex. We're going to spend a ton of time on this slide debunking all of these acronyms, so buckle up. We're going to talk first about a case from our center from this past year to illustrate selection of temporary MCS as bridging to heart transplant, and then dive in a bit to the factors that I think are most helpful for identifying those patients that will respond favorably to counterpulsation. And then finally touch on a little bit of the outcomes data for balloon pump as a bridge to transplant. So we'll start with our case. So this is Verna. She's a 51-year-old woman. She's got a dilated non-ischemic cardiomyopathy, long-standing, EF of 25%. She has a previously severe functional MR and had a mitral clip a couple of years prior with residual mild to moderate MR. She's got secondary pulmonary hypertension, HIV that's well controlled on heart, and type 2 diabetes well controlled on oral agents. She's been at home on dobutamine for 9 months, enlisted status 4 for transplant. She's blood type O. She's a petite woman, under 5 feet tall, so she and I are quite a pair next to each other. Fairly sensitized. She has CPRA of 51%. She'd been admitted twice in the last 6 months for decompensated heart failure despite the inotropic support. And now she's coming in with worsening shortness of breath, chest pressure, and really diffuse abdominal pain. This is her initial presentation. She's tachycardic, typical for heart failure shock patients, has a preserved blood pressure, but very narrow systemic pulse pressure. elevated jugular venous pressure, an S3 gallop. Extremities are slightly cool, but not much edema. Labs are notable for worsening renal function with a creatinine of 1.4 up from a normal baseline, elevated liver function tests. Her NT-proBNP is markedly higher at over 12,000 up from a baseline of 3,800, and she has a normal lactate. Her EKG was just notable for sinus tachycardia. These are some representative images of her admission echocardiogram. Notably, she's got a dilated, somewhat globular left ventricle, ejection fraction of 25%. She had residual 1 to 2 plus mitral regurgitation. You can see the mitral clip there. And importantly, she's got fairly preserved right ventricular geometry and systolic function. So she, out of concern for cardiogenic shock with the end organ dysfunction, she gets placed in the CCU and started on nitroprusside in addition to dobutamine. She has a PA catheter placed, and the hemodynamics are here. I'll highlight again sort of marginal systemic pulse pressure and blood pressure. She's got markedly elevated wedge pressure, and particularly PA pressures with a mean PA pressure of 47, a mixed venous of 41%, giving her an index of 1.8 and an SVR of about 1,500. That's on dobutamine and nipride. So now, technology being what it is, and technology is boring, so we're not going to use the QR code. We're going to have you guys stand up in response to these so you can see your cohorts of who wants to do what you want to do, and then you can meet up afterwards. So just to remind you, so Verna's 51, long-standing cardiomyopathy. She's on dobutamine at home. She's now on dobutamine and nipride after presenting with SCAI stage C, heart failure, cardiogenic shock. What would be your next step in management? So I'll read them all off, and then we're going to stand up to vote. So we could either add another inotrope like milrinone, place a balloon pump. Don't be biased by the session. You can't all vote for that. Place an Impella CP, place a Impella 5.5, or put her on VA ECMO. All right, so who wants to do A? Come on. No one? Okay. All right, what about B? Gotta stand there, Brian. That's my man. Okay, we got a lot of B's. I like it. What about C? Someone's got to be in on C with, sir, what's your name? Patrick. Somebody was with Patrick? No one? Okay. What about D? Yeah, okay. Good. Andrew. What about E? Okay, good. No takers for E, which I think would be probably excessive, right, at this point? Yeah, we noticed you guys that didn't stand up. There's another question coming, so be ready. Gary's proved that we can all stand and do it, even if you had a balloon pump in. All right, so these are the updated hemodynamics 24 hours later. So you can see she's got a pretty marked improvement in hemodynamics within 24 hours. So her wedge is down to 18. Her mean PA pressure came down 16 points from 47 to 31. Her mixed venous is up to 62%. So her index is now 2.9 with an SVR of 1,100. So very nice initial hemodynamic response. So with this as a backdrop, I wanted to look at what are the data that we have for using counterpulsation and heart failure cardiogenic shock, and what are the features that could identify particular responders to this therapy. So this is data that's going to be published in the Journal of Cardiac Failure in the next month or two, and this is an analysis that our group led that was really spearheaded by Rashad Garan, an analysis of the cardiogenic shock working group data of nearly 900 patients with cardiogenic shock who received a balloon pump as their first temporary MCS device. And you can see just under half the patients had heart failure shock, and about 43% had AMI shock. And the Kaplan-Meier plot here, you can see the 30-day survival free of device escalation was significantly better in the heart failure shock population compared to AMI shock. And notably, amongst the heart failure shock group, about almost 2/3 of them had what we would consider a favorable outcome. So a third of them had native heart recovery and had the device explanted, and just under 30% were bridged successfully to heart replacement therapies. So I think this is some real world data that kind of highlights some themes that have been coming out of multiple publications of the last few years. Number one, that heart failure, cardiogenic shock, and AMI shock are somewhat distinct clinical entities. And number two, that balloon counterpulsation can have a role, at least in a subset of the heart failure, cardiogenic shock population. Well, we, of course, need to discuss this really nice randomized trial, ALT-SHOCK 2, that was just published in JACC this past month and presented by Dr. Pappalardo and colleagues at the ACC meeting. This is really the first randomized trial that's ever been done in the heart failure shock space. And this was randomizing patients with heart failure shock to early intra-aortic balloon pump. So that was within the first 6 hours of randomization, or standard medical therapy. Importantly, these were patients that had to be candidates for heart replacement therapy. So they had to be fairly young, 75 years of age or younger, and without any severe comorbidities that would prevent heart replacement strategies. Predominantly a SCAI stage B and C population. Ultimately, the study was stopped early by the DSMB for futility, and you can see the Kaplan-Meier plot of the primary outcome here, which was 60-day survival or successful heart replacement. And of note, while there's no difference between the balloon pump and medical therapy arms, the outcomes were very good in this population compared to what we might expect. So 81% of the balloon pump patients had success at 60 days, and 75% of the medical therapy arm. The medical therapy arm did much better than expected. And so while the conclusion of this trial was ultimately that in chronic heart failure shock, early intra-aortic balloon pump didn't significantly improve outcomes compared to medical therapy, I would highlight, this is definitely a selected population of fairly well patients in the heart failure shock space, but also that the outcomes were quite good. So for patients who are sliding despite medical therapy, like in our case, balloon counterpulsation, I think, remains an important consideration. So how do we pick these patients? We'll focus for the next few minutes on the features of responders. This is a study from WashU, about a decade old now, of over 50 patients who are awaiting durable LVAD. Remember when we did those? We still do. Just over half of them stabilized well with balloon pumping, and 43% deteriorated despite balloon pumping. And they looked at factors that were associated with stabilizing, that's in light green. And the key things were that the baseline left ventricular and right ventricular cardiac power index were higher in those patients that stabilized. And also the patients that stabilized tended to have higher baseline PA pressures, here the PA systolic. And they developed a simple sort of score based on RV and LV cardiac power index, that if you had those power indices above those thresholds, you were very likely to stabilize well with a balloon pump. Well, this is data that Rashad published when he was in Colombia, and this is a large series of patients with chronic heart failure shock who are bridging predominantly to heart replacement therapies, and the outcomes were quite good overall, with nearly 80% successfully getting to transplant. But maybe the most important thing that this study highlighted, which is sort of emphasized in this figure, is the heterogeneous response to balloon counterpulsation in the heart failure shock population. You can see this is the change in cardiac output after balloon pump. And this was really within the first 12 to 24 hours after balloon pump, when the hemodynamics were reassessed. You can see there's a small subset of patients that actually get worse in terms of cardiac output, even despite the device. And then there's a significant subset of patients, so-called super responders, that are increasing their cardiac output by more than 2 liters per minute. So this is a really important concept, that not all patients are going to respond in the same way. And when they looked at factors that were associated with clinical deterioration, and that was device escalation or death on balloon pump. It was patients that had ischemic cardiomyopathy or had worse RV function as identified by lower PAPI that were more likely to deteriorate on balloon pump. So then they went on to further analyze this cohort, now adding, importantly, the change in mean PA pressures. And I want to emphasize that this relief of congestion or improvement in congestion in the heart failure shock population is probably just as important, if not more important, in terms of driving outcomes than improvements or increases in cardiac output. So you can see, just like the heterogeneity for cardiac output change, this is the bottom plot is the change in PA pressure for each of the patients. And many of them have a pretty dramatic improvement in PA pressures early after balloon pump within the first 12 to 24 hours. And so when they group patients into this super responder category based on improving cardiac output and reducing mean PA pressure, the factors that were associated with failure to respond were ischemic cardiomyopathy, a smaller left ventricular dimension, lower PA pressures, lower heart rate, less mitral regurgitation, which we'll come back to, and lower SVR. And in multivariable modeling, it was really the presence of significant mitral regurgitation and a preserved SVR that most strongly correlated with a favorable balloon pump response. Now, this is data from Houston Methodist, Arvind and the gang down there. This is almost 200 patients who had balloon pump bridging to transplant, again with fairly good outcomes, nearly 70% successfully getting to transplant. And they looked very similarly at the factors associated with clinical deterioration, again, death or need for device escalation, with some similar themes emerging of patients that did poorly, had smaller LV cavities, had RV dysfunction, now as evidenced by higher RA to wedge pressure ratio, and again, ischemic cardiomyopathy. So this table highlights what I think is sort of a summary of the key factors that you can think about for favorable response to balloon pumping. And I try to lump these into like three pillars of favorable balloon pump response. Number one is in red is you want patients that have LV dominant failure. That doesn't mean the RV has to look perfect, but you want a phenotype of predominant LV failure. So ideally not seeing severe RV dysfunction on echo, but more importantly, favorable right heart hemodynamics, so lower RA to wedge ratio, higher PAPI, higher RV cardiac power index. Number two, and I think this was highlighted in a couple of studies, including from Columbia and from Hopkins, that patients with reversible left heart congestion, as represented by higher PA pressures and particularly significant mitral regurgitation, are more likely to respond. Remembering that MR is a lesion that's particularly responsive often to counterpulsation, where balloon deflation in the aorta prior to systolic ejection helps to favor forward stroke volume rather than regurgitation through the mitral valve. And number three is what I term like cardiac output reserve with afterload reduction. Well, what does that mean? Patients that have a phenotype of some reserve to increase their stroke volume. And those features include chronic heart failure patients as opposed to AMI shock, non-ischemic cardiomyopathy, and probably most importantly is avoiding in patients with like dense infarct cardiomyopathy where there's not a lot of residual myocardium to recruit, patients with more dilated left ventricles where the wall stress is going to be relatively higher for any given aortic pressure, are more likely to respond, and then preserved SVR and relatively higher LV cardiac power index. So let's get back to Verna. I told you already she had a nice hemodynamic response, but how's she feeling? Well, within the first 24 hours, abdominal pain, gone. That was probably all a low output feature for her. Urine output's picking up. End organ function is improving with creatinine and liver function tests. So now get ready to stand. Get prepared. We have to figure out how we're going to get her to transplant successfully, right? Remembering that she's blood type O, she's fairly small, but she's sensitized. So now we only got 3 options, so that should make it easier. We've got, oh, don't stand up yet. We've got continuer on the balloon pump. We've got transition to Impella 5.5, and we've got transition to VA ECMO. So who wants to continuer on the balloon pump? And we have to stand. Okay, it's better from the back corner. Not bad. What about transition to Impella 5.5? Okay. Good. Excellent. Very reasonable. VA ECMO. Love that. This crowd hates ECMO. So what data do we have for using the balloon pump to bridge? Like, how well does that work out? There's a bunch of studies. I only have time to show a few. This is a large series from Spain. The Europeans are always ahead of us, I feel like, right? This is nearly 300 patients who are bridging to a transplant with balloon pump. And you can see the competing events here, but patients overall did very well. More than 80% of them had a favorable outcome at a month, with 65% getting transplanted, some actually getting weaned off the device, some remaining on device, only 7% dying while on support. And how does the balloon pump compare to Impella? And what's the North American experience? So this is UNOS data, an analysis led by the group at Tufts, comparing patients from 2014 to 2020 who bridged to transplant with a balloon pump versus Impella. Only 11% Impella, I'll highlight. And Impella patients were significantly sicker at baseline, so end organ dysfunction scores and comorbidities were higher in the Impella group, which is important to note. And they looked at the waitlist mortality, and you can see the overall cohort in panel A, and then propensity match to try to adjust for those baseline differences in panel B. But in both approaches, the waitlist mortality was significantly lower with balloon pump. I suspect a good bit of that is driven by residual confounding from level of illness in the Impella patients, but I want to highlight that the waitlist mortality for the balloon pump patients was quite low. This is a similar analysis of UNOS a couple years later by the group at Penn. This is now the modern allocation era from 2018 to 2021. Now 83% of patients with a balloon pump and 15% with the Impella 5.5, so our modern biggest Impella. Again, they saw the same features that the Impella patients had evidence of being sicker at baseline. And when they looked at the cumulative incidence of transplant in panel A, that was actually, if anything, significantly higher, better in the balloon pump group. And then most importantly, panel B, the post-transplant survival was no different between these two groups. So if you have a patient that stabilizes well with balloon pumping, there's no reason to think that they can't continue that response and get safely through transplant. And as Gary highlighted for us, well, even with the femoral approach, there's no reason that we couldn't be ambulating them as they await their heart replacement strategy. So in summary, I've tried to show you that I think there's a significant proportion of heart failure cardiogenic shock patients that can have a favorable response to balloon counterpulsation. There's some key clinical echo and hemodynamic factors that can help us, I think, stratify for a greater likelihood to respond to balloon counterpulsation. And those are these pillars of LV dominant failure, reversible left heart congestion with higher PA pressures and more MR, and cardiac output reserve. And finally, the outcomes, if people respond well to balloon pumping in terms of waitlist mortality and post-transplant survival, are generally quite good and pretty comparable to other devices. So I'll finish there. I'll let you know that Verna did get transplanted about 8 days later and is doing quite well. We'll finish off. That's the crew. Thank you all.